Malignant pleural effusions, oncological emergency. A malignant pleural effusion, MPE, is the buildup of fluid in the space between the lungs and the chest wall, caused by cancer cells, metastatic disease. It is considered an oncological emergency because it can rapidly compress the lungs, leading to severe breathing difficulty. Management focuses on immediate symptom relief and long-term planning. The key nursing priorities are managing the breathlessness, prioritize high-flow oxygen, and positioning the patient upright before considering opioids, which can slow breathing. Ensuring procedure safety. Any fluid removal, thoracentesis, must be guided by ultrasound to prevent lung damage. Educating on long-term drains. If a permanent drain, indwelling pleural catheter, is placed, teach the patient/family strict sterile technique and the exact fluid drainage limits to prevent infection and shock. Aligning with the patient's goals. Ensure all interventions match the patient's prognosis and wishes for quality of life. Watching for complications. Monitor closely for a collapsed lung, pneumothorax, or, after fluid removal, rare but serious fluid buildup in the lungs, re-expansion pulmonary edema. In short, relieve the breathlessness, ensure safe drainage, educate for home care, and always keep the patient's goals at the center of care. Patient, Ms. Eleanor Reed, 70-year-old female with metastatic lung adenocarcinoma. Presence with acute dyspnea. Clinical presentation. History, diagnosed 6 months ago on pembrolizumab. Previous MPE drained 3 weeks ago. Vitals, BP 148/90, HR 118, RR 34, SpO2 84% RA, temp 37.1 degrees Celsius. Physical exam, PE drained 3 weeks ago. Asymmetric chest expansion, right-left. Dullness to percussion over right lung base. Absent breath sounds right lower lobe. Tracheal deviation to the left. Symptoms, can't breathe lying down, pleuritic right-sided chest pain, fatigue. Imaging, STAT-CXR shows large right pleural effusion, greater than 50% hemothorax. Immediate nursing action. A. Administer IV furosemide. B. Apply high-flow oxygen. C. Give morphine sulfate IVD, position supine. Answer B. SpO2 84% equals severe hypoxia. Oxygen supports perfusion. Key physical finding indicating malignant pleural effusion. MPE A. Bilateral crackles. B. Absent breath sounds plus dull percussion. C. Wheezing on expiration. D. Egophony. Answer B. Classic triad for effusion. Dullness, absent breath sounds, decreased fremitus. Priority diagnostic test. A. ABG analysis. B. Thoracic ultrasound. C. 12-lead ECGD, sputum culture. Answer B. Ultrasound guides safe thoracentesis, reduces pneumothorax risk. Provider orders therapeutic thoracentesis. Nurse prepares. A. Verify IN R/platelets. B. Position in left lateral decubitus. C. Administer IV antibiotics. D. Insert urinary catheter. Answer A. Bleeding risk. Platelets over 50K/mm superscript 3 and IN are less than 1.5 are required. During thoracentesis, patient coughs violently. Nurse suspects. A. Pulmonary embolism. B. Re-expansion pulmonary edema. C. Pneumothorax. D. Bronchospasm. Answer B. Cough plus rapid fluid removal equals re-expansion pulmonary edema. Post-thoracentesis, SpO2 drops to 79%. Priority action. A. Increase O2 to 100% non-rebreather. B. Obtain STAT portable CXRC. Administer albuterol nebulizer. D. Notify provider in 15 minutes. Answer A. Increase O2 to 100% non-rebreather. This is the immediate priority. The patient is in a state of severe hypoxemia, SpO2 79%. The brain and heart cannot tolerate low oxygen levels for long. Applying high-flow oxygen, 15 liters per minute via non-rebreather mask, is the fastest way to support vital organ perfusion while you assess the cause. You cannot troubleshoot the reason for the desaturation if the patient is crashing from lack of oxygen. Obtain STAT portable CXR. This is a critical next step. A chest X-ray is essential to diagnose the most likely complications: attention pneumothorax, or re-expansion pulmonary edema, fluid in the lung tissue. However, you must stabilize the patient's oxygenation before or while waiting for the X-ray to be performed in red. If the patient is unstable, a needle decompression might even be needed before the X-ray confirms. Contraindicated positioning for MPE: A. High Fowler's B, Trendelenburg C, orthopneic position D, right side lying. Answer B. Trendelenburg increases intrathoracic pressure, leading to worsens dyspnea. Patient develops subcutaneous emphysema. Indicates: A. Fluid overload B, tracheobronchial injury C, anaphylaxis D, sepsis. Answer B. Crepitus equals air tracking from pleural space. Pleurodesis ordered. Nurse explains: A. Will instill medication to scar the pleural space. B. You'll need lifelong chest tube. C. This cures the cancer. D. It prevents pneumonia. Answer A. Pleurodesis creates inflammation leading to pleural fusion. Indwelling catheter placed. Key discharge teaching: A. Drain fluid when short of breath. B. Clamp tube if drainage greater than 200 milliliters. C. Soak in bath daily. D. Avoid all pain medications. Answer A. Patient-controlled drainage improves QOL, drain PRN dyspnea. Patient asks about prognosis. Therapeutic response: A. MPE is manageable. Focus on symptom control. B. You have 3 months to live. C. This means treatment failed. D. Only surgery can help now. Answer A. Balances honesty with hope. Median survival 3 to 12 months. Risk factor for rapid reaccumulation: A. Age greater than 65. B. Adenocarcinoma histology. C. Hypertension. D. Previous smoking. Answer B. Adenocarcinomas secrete VEGF, leading to rapid fluid reaccumulation. Nurse notes continuous bubbling in drainage system. Action: A. Check tubing connections. B. Clamp the chest tube. C. Increase suction pressure. D. Administer antitussives. Answer A. Bubbling equals air leak. Check connections before clamping. Post-procedure, patient develops hypotension plus jugular venous distension. Suspect: A. Myocardial infarction. B. Tension pneumothorax. C. Pulmonary embolism. D. Sepsis. Answer B. Hypotension plus JVD equals tension pneumothorax, which is a medical emergency. Priority intervention for chest tube dislodgement: A. Apply occlusive dressing. B. Reinsert the tube. C. Administer 4 fluids. D. Place in Trendelenburg. Answer A. Occlusive dressing prevents pneumothorax until tube reinsertion.
MPE critical safety alerts. Never drain 1.5 L initially, risks re-expansion pulmonary edema. Tension pneumothorax signs. Tracheal deviation plus hypotension equals immediate needle decompression. IPC drainage limits. Maximum 1000 ml/session. Stop if chest pain/cough develops. Geriatric considerations. Reduced pulmonary reserve rightward arrow tolerate hypoxia poorly. Sedation risks during procedures rightward arrow use minimal midazolam.
Malignant pleural effusion, MPE, emergency protocol, breathe easy mnemonic. Baseline vitals, SpO2/RR priority. Rapid imaging, CXR/ultrasound. Elevate HOB 60 degrees. Avoid rapid drainage, 1.5 L/24H. Thoracentesis prep, coagulation studies. High flow O2, target SpO2 greater than 92%. Emergency pneumothorax kit ready. Educate on IPC drainage technique. Assess for re-expansion edema, crackles/SpO2 drop. Sterile dressing changes, IPC site. Yield to patient preference, goals of care discussion.